I feel like we haven't been together for a while. It's been over a week, which in iPad land is a long time. But last week I just kind of wanted to tell you guys, so you're getting ready and you're getting excited for phase 2. That's where I was last week. I was doing a site inspection visit for accreditation, and there's so much goodness happening out there. Like, they're so excited for you guys to come. They're so excited to teach. They're so excited to have you. So I hope you guys are starting to get excited and start. I know you guys are ready to be done with this, but also I hope you're really getting excited for what's to come, because it's going to be really good. So on to the next. We are finishing all of block 2 this week. So we are cramming a lot of the bread and butter pediatrics. So what I need you guys for this week is to really hang on to all things pediatrics, because I'm going to try to shove all of the bread and butter of what you're going to be expected to do as a primary care PA into 1 week. So hang with me for like a week, okay? We got this. But we need to know where we were coming from then, because it feeds into our lecture today. So our last lecture was about pediatric fever and some of those big diagnoses associated with fever, meningitis and encephalitis. So just as a refresher, when you have a child with a fever and who has an underlying diagnosis of epilepsy, what does that fever do to a child's seizure threshold? Good. What is your dose of ibuprofen for a child who has a fever? 10, not 10 to 15. 10 mgs per kg. Every 6 to 8 hours. Yep. What is your diagnosis, or what is your dose of Tylenol? That's the 10 to 15. Every 4 to 6 hours. Yep. How old do you have to be to give Tylenol? 2 what? Months. How about ibuprofen? 6 months. Yeah, 6 years, that would be wild. Okay, an infant is under 90 days old, and you're concerned, what disease process are you going to add acyclovir for when considering the empiric treatment for a toxic aperitif child? If you hear fever and a petechial rash that is diffuse, Neisseria, what is your empiric treatment of Neisseria for a child with fever and a petechial rash? I'm hearing some. Yep, ceftriaxone or cefotaxime. UTIs. What are some of the things that make you higher or lower risk in that first year of life? Being female? If you are male, what's going to make that higher or lower? Uncircumcised, good. Yeah, and then any other anatomical abnormalities. A defect in your complement pathway makes you consider what diagnosis? Remember what complement pathway was? It's that triggering event that starts your immune system and everything. So if you ever hear complement deficiency, it's like fever and a petechial rash. It's the same thing. Neisseria. It's complement deficiency. Do you need to do a CT scan before you do a lumbar puncture in a child routinely? Unless they have ICP. Good. Good. Okay, and the reason that you need that fever lecture first is because of what we talked about in that lecture is a third of all of the visits are going to deal with some sort of fever in a child. And most of the time, parents are going to come into an ER, an urgent care, a primary care clinic and say, there's a fever and a rash. There's a fever and a rash. There's a fever and a rash. And your job will be to say, is this a viral type rash? Is this bioterrorism? Is this one of these pathognomonic, highly testable for our pants things? Is this something I need to be concerned about or not? So if you start on this next test in real life and on your pants, you hear fever and a rash, fever and a rash, fever and a rash, and you're like, hey. Yes. So that's what they were going to try to do for this, and that's what happens in children. And so the reason that we're having a soul-specific lecture on it, because you're like, we already had infectious disease we got a lot of immunizations for all this stuff. Couple of things. We're seeing a resurgence, and we'll talk about some of those. But number 2, this is high pants fodder. And number 3, with that resurgence, I predict that we will all get to learn about diphtheria together, right? Again, when it comes back. So some of these things we are going to see again. So you saw all of these in your infectious disease class. That said, when you are studying this, when you're studying all of these things, if you're like, we were already tested on the transmission, we were already tested on all of the incubation period and all of that fun stuff, that's not where I would spend your time. Make sure you have a good refresher of that, but how does that change with a kid? Apply that to pediatrics and what I'm talking about specifically with a child. I'm not retesting infectious disease. Does that make sense for the way you are going to study this? So when we talk about infectious disease in kids with fever and rash, your new provider terminology is not going to be like, that's a rash on a kid, that's a viral rash. We're going to call those infectious cutaneous exanthems. Infectious, meaning it's an infectious etiology, so some sort of virus, bacteria, fungus, parasite, something is causing this. Cutaneous, it's manifesting on the skin, and that is an exanthem. Exanthem is the fancy provider word for skin rash, right? You can have an enanthem, so it's on the endomucosal surface, or the exanthem. So that is what a lot of times you can do. So someday when you are diagnosing a child with a viral exanthem, and the parents are like, what in the world is that? You will know that you just told them what they just told you. They have a rash, and you're like, ah, yes, you have an exanthem. And that is your diagnosis, really. Okay, so just so we're on the right terminology. And there used to be this historical numbering. We didn't have fancy PCRs and IgMs, IgGs. We didn't have all of that collectively as a medical entity. And so we started numbering this based on these highly communicable, highly predictable patterns of how they looked. We, as providers, used to say, this is second disease, this is fourth disease, this is sixth disease. And so collectively, as we've numbered and changed and medicine has evolved, all of this numbering system really has dropped, except for which one? Fifth disease, yeah. So that is really the remnant of that historical naming system that we used. So you could look really fancy and smart if you just started using this kind of numbering, because people are supposed to know this, and I guarantee you most providers don't know it. What I will tell you for my test with this, I am going to use measles and rubella. That is how I'm going to classify them. I'm not going to try to trick you with rubeola and German measles. I will use measles and rubella. That said, on your pants, rubeola is fair game. Okay, so when you're like, oh shoot, which one was it? Rubeola and German measles is fair game for your pants. So be aware of that when you are studying for that pants prep, right? So we are going to talk about all of these and their patterns in that specific order, and we will start here. So just first off, note, measles is rubeola. So that's the first one that we are going to talk about. Interesting BBC report that just came out, let's see, 24th, so the 22nd on Saturday. 100 cases now in Texas and New Mexico in February, right? So we are seeing this resurgence of this come up. Remember the last big outbreak that we had in this country from Disneyland, right? For measles, we had this Disneyland outbreak. 2023 numbers, they haven't released 2024, but 2023 numbers, there's only 58 cases in the whole United States, right? So one state, if we're going to average that, maybe you're not going to see it. You're likely to see those clustered together. However, if we have 100 in the last couple of weeks right here locally with us, we might well be seeing that sooner than we think we're going to. Okay? So very, very, very highly contagious. When it was a non-vaccine preventable disease, most kids were going to get this. It was probably how many of us grew up with the chicken pox. It was one of those, you're a lock for it. Once the vaccination took hold, we saw those numbers drop dramatically. This is a very stable antibody, so the vaccine holds antibodies well. Right? Stable antibodies, so if you have been vaccinated against this, you are likely to remain as such, specifically for measles. One of the things and the problems, because it is so contagious, is that you need high amounts of herd immunity for this to work at all. And when I say high, for this particular case, you need at least 95% immunity. So that's totally fine if you have 1 or 2 kids that are unvaccinated here or there. When you get more than 5 out of 100, you've suddenly lost your herd immunity. So that is one of the reasons why it is so important to keep those vaccination numbers high, because specifically for measles, you'll see outbreaks immediately as soon as you go below 95. And again, those are all epidemiology. Please don't spend time, just be aware of the concept. Don't spend your time learning specific numbers to do with this. So the virus itself, in basically any of your fluids, so it can be in your saliva, it will be in your blood, it will be in your urine, so easily contracted from one individual to the next. Most of the time it's going to be spread with respiratory and saliva secretions, and it can linger up in the air. It is not a super heavy particle, so it can linger up in the air for about an hour, which is why Disneyland was the absolute perfect place to spread this, because you would have a sneeze, a cough, some sort of child throwing a fit, whatever it was, and you have these particles lingering in the air, people standing in line just walking through those particles, right? So if you think about how that spread, it was a perfect setup for that. That's why daycares will require vaccination records. That's why you'll see any places where you have large groupings of children, the mommy daycare at the gym, Girl Scout, Boy Scout groups, all of those places that will require vaccination records for these specific reasons. The other thing, because I had said that the antibody is so stable, this is one of the good things about breastfeeding. When the mom transfers antibodies, this is a particularly stable antibody. So they have about a year's protection if they're getting breastfeed from mom. So a year is a long time for an antibody from mom to remain stable. So this is one that we particularly like and capitalize on, and this is one of the reasons why the MMR vaccine was set for the 12-month visit, because at the 12-month mark is about when you start seeing those antibodies wane enough that they don't have protection any longer. So if that helps remember it at all, it's the year mark when they get vaccinated. This particular disease in children is going to come in these 4 phases. And these are 4 very distinct phases that for your pants is high yield and for me is high yield. So what is happening in the incubation period, your prodromal period, what is the xanthan that goes with this, the fever and the rash, and then the recovery. As with most viruses, you're going to be infectious before you even know you're sick, and then after for a while. So it's about a week's long of infectivity that you see here. I would start this one to be aware of all of these 4 different times. So the incubation period for measles is pretty long, almost 2 weeks. So if you're thinking about this from a historical standpoint, if you have a patient who is coming in and you know they're unvaccinated, you need to be thinking, what did you do 2 weeks ago? Right? That's how you're going to have to ask this history, not what happened a day or 2 ago, because the incubation period was so long. What happened 2 weeks ago? And that's really hard for humans and parents. For you parents out there, if I was like, what did you feed your child for breakfast this morning? You're like, I have no idea, right? And as humans, we even are like, what did you eat for breakfast this morning? And you're like, there was breakfast? I don't even know who I am right now. So it's a hard thing to ask people to do, is to recall from 2 weeks ago. It's going to be required to be able to get a good history for this. The long incubation period, then you have your prodromal period. And this one is hard because it looks like everything else. If you start really looking at this, you're like, for 3 days you don't feel great, the kid has a pretty high fever, and they have a cough, a runny nose, and eye goop, right? So you're like, that sounds like every infectious thing that a child comes in with. That sounds like everything else. And you're like, yes, that is exactly right. A couple of things to note then, specifically with measles, is that the fever of measles is relatively high. Really, there's no, remember, low grade, high grade, all of that stuff. But as far as fever goes, it's pretty uncommon that you spend a whole lot of time sustained up in 104, 105 range. It's pretty high. Is that harmful high? No, but it's something to be characteristic if they are spending that much time for those 3-ish to 5-ish days up in that period of 104 to 105, that's different. And then classically, it goes with cough, coryza, which is your fancy provider way to say runny nose, and then conjunctivitis. So again, that's going to match every child. Your pathognomonic thing that you're going to see are your Koplik spots. Does anyone remember what Koplik spots look like? Yeah, they're kind of, I've never seen them in real life, but they're kind of this white, gray, looks like a little sand in the mouth. And how long are they there for? Yeah, 24 hours, so 12 to 24 hours. They're very brief. So if you see them, it can be nothing else. It has to be measles. If you don't see them, does that mean it is not measles? No. Right? So if you catch them, great. If you don't, yes, sir.
Is that fever responsive to antibiotics?
Yeah. So it's still responsive to antipyretics. A lot of times it'll, if it's up in the 105 range, you bring it down and they're comfortable into like 101. Yeah. So now you've had this long incubation period. Now you've had kind of feel like everything else, every other thing that a child gets. And now is the xanthums part. So now is that rash that comes on. So the reason, and this one is particular, and so these is what I need you guys to focus on, is what is the pattern of rashes. So this pattern rash starts in your hairline and works its way down the body. So that is very characteristic of measles. Starts in the hairline, works its way down. The interesting thing about this rash is that typically the severity of the illness is determined by how far the rash goes down. So super just kind of interesting thing to know about that. Then it's going to, in the recovery system, much like when we talked about hyperbilirubinemia and jaundice, it's going to resolve in that same pattern. So it's not going to resolve where it started. It starts from the bottom back up, works its way up. And it kind of turns, as most things do, a little brownish and can desquamate. So things to look for, specifically for this one, that pattern from the hairline down. It's not itchy, so it's not pruritic. It desquamates, and then that extent of the rash. And so those are the patterns I need you guys to know for all of these different examples. We talked about the Koplik spots, a couple of different examples, and if you see them, it is that and nothing else. It can be nothing else. They are pathognomonic, meaning that is that. Certainly if you see a child, and what I will give you for the pants, there is no way to test this other than if you say, the unvaccinated child, the child who was recently adopted that you have no medical records for. It's another way of saying unvaccinated. They will have to give you something because the standard of care is vaccination in this country. So they have to give you something on a test that will tell you that they are unvaccinated. Or they will tell you they've gotten all their routine care and they have an immunodeficiency where they do not make antibodies. So they will give you something to let you know that there is not a normal antibody response. If they give you something like this, they can't just give you a rash. I guess they probably could. They'll have to give you a pattern. They have to give you something else with this. So this is a more biliform rash, full, starting with the head, working its way down. Your diagnosis can be just made with Koplik spots. You had that. Can be made with clinical diagnosis, or it can be done with an RT-PCR. So this is not a clin lab class. I am not going to spend time trying to test you. I might throw some of the diagnostics in, but my goal is to not test you on the infectious disease part of that. For your labs, they really aren't going to be all that helpful. There's nothing on a CBC or a CMP, unless you have a dehydrated child, that's really going to help you all that much for measles. But something specific to be aware of this is one that is required that you tell the local health department. And so if you're like, well, who's going to tell the local health department? That would be you as the provider of the team. So when you have something that is a reportable disease, so whether that be gonorrhea, chlamydia, measles, dog bites, whatever it is, that is one thing that you will need to learn at your phase 2 when you are in family health or when you're in those clinics. What is reportable? What am I responsible to report? So this is one of your reportable ones. How do you treat it then? So this is the big thing. How do you treat it? These are the things I need you guys to know. More than RT-PCR, don't care about that. How am I going to treat this as the PA? Well, you need to make sure this kid stays hydrated because that's going to get them down a spiral real fast and stays comfortable. As our friend back there was saying, if you have those fevers in a 104, 105 range, what is your heart rate doing? It's tachycardic. What is your respiratory rate doing? It's tachypnic, yep. So what does that mean for your amount of hydration? Are you losing it faster or slower? Faster. So you have a kid who is already on the brink of becoming dehydrated, whose body is not feeling well, so your biggest treatment is to keep this child hydrated, however that can be. The other thing that is recommended is a dose of vitamin A. So vitamin A does not cure measles, but if you are low in vitamin A, you are going to have a more severe disease process. So it is one of those that is supplemented and given to places that do not have vaccination to help prevent the severity of measles. What are the complications of this? Well, it's a pro-inflammatory state, so you have those positive cytokines and inflammatory markers everywhere, so you can have those secondary sequelae that happen that are pretty common for any type of virus. So pneumonias are very, very common for this if you have less respiratory clearance. Otitis media, because there's often younger children, and then some CNS complications just given the specific pattern of where this virus goes. Never seen measles, I told you that, never seen that, so certainly never seen these long-term complications. If you see these like subacute sclerosing panencephalitis or encephalomyelitis, if you see any of those, I beg of you, please call me because this is a super cool case report and super interesting. And you are the rock star of all rock stars of PAs if you are the one diagnosing this. So please call me because it'll be very interesting. Couldn't hit this any harder, I'm not sure. Prevention is the biggest key, so vaccination. This is a live vaccine. This is their first vaccine. I was just looking it up last night because I was interested, you might not be, but I was, of why did they put MM and R together? Like why these three? It was really just they had these three ready to go. They were all viruses that had highly effective vaccinations, and they were like, what if we put them in one poke? How is that going to work out? They did some studies in 1969. It was a go, and it's been a go ever since, right? So there's really not anything where there's some specific something with these three entities. It's more than anything, it's historical at this point, and it is what it's made. So first live one, right at that year mark where your antibodies wane. A second one, which is right before school, right before we know you're going into an environment with a whole lot of kids in a close proximity. We give that booster shot, or that second vaccine to boost those antibodies. The difference between your MMR and your MMRV, what's the V? Varicella. And super interesting, when we gave the combination vaccine, MMRV, at 12 months, we saw an increase in febrile seizures in these kids. Once you take the varicella component out, you don't see that. Varicella component in, febrile seizures. Varicella component out, no febrile seizures, or certainly much less. When you put the varicella component back in at age 4, you don't see those febrile seizures again. One of those things epidemiologically and data-driven that we did from VAERS reports, from those vaccine adverse reaction reports that we saw and made a change based on that. Can't give this because it's live to immunocompromised children and certainly any pregnancy-related times, so one of the things to look at. Because it is so contagious and you want to clamp down that amount that is contagious, there are a couple of things. Because the incubation period is so long, if you have a known exposure, you were like, man, I was at Disneyland that same day, I've never been vaccinated or my child's not been vaccinated, there are some options to be able to give the vaccine if it's within those 72 hours, or you can give your immunoglobulin within that first week. So that's where knowing the incubation period as a provider and what the specific history of a patient can be helpful because it can change your management. Yes, sir?
And how does that change if they've gotten like one dose and on the second, or if they've gotten both doses? Do you still do some kind of post-exposure following for that?
Great question. No, this would just be if they had never had any. Yeah, so if they, let's say they're 2 or 3 years old and so they've had one vaccine but not your second one, they are on schedule. They, in theory, have the correct amount of antibodies as long as they have a functioning immune system and you let it lie. Good question. Okay, so that is measles, specifically for the child. So when we think now of what was second disease, does anyone remember from the list? Scarlet fever, okay? We're gonna come back to that one way later to do with the heart and rheumatic fever stuff. So, yep, you got that one. Now, we go down into rubella, or German measles. The way I think about this is that this is measles light, okay? Measles light is how I need you to kind of conceptually wrap your head around it. So if you're thinking, well, measles really wasn't all that deadly, I know it's really contagious, but like, why is rubella one that we really care about? Great question, I'm so glad you asked. So there's really, the reason to vaccinate is for a couple of things, especially in childhood. Number one, it could be for the child themselves. This could be a time where a child is vulnerable to whatever the disease is that could kill them. Let's think about rotavirus, for example. Infectious diarrhea. It's probably not gonna get you or I, right? We can say, I can stay hydrated, I can take myself over to the ER, I'm okay. It's miserable, but I'm okay. A small baby, more likely to die from dehydration, especially in countries that don't have access to healthcare, okay? So that could be one of the reasons we vaccinate for this child. The other reason that we can vaccinate for children is because children are gross, and they are become the vectors to other people, and that can be very harmful. So rubella itself, not super harmful to healthy kids, super, super harmful to pregnant women. Okay, so who is most likely to have this then? A mom or somebody else who is pregnant with now a toddler. Okay, so either it's going to be really bad for some population of adults if they're exposed, or it's going to be bad for the kid. In this instance, it's really bad for the specific adult population, so we'll talk about some of that. So adults that get this, just in general, are going to have a worse course. So certainly if we can vaccinate early, can prevent adults having a worse course. But again, those pregnant women, if they get the actual disease process, it can lead to congenital rubella syndrome in the baby. And we have lots that we're going to talk about on that, because I will need you to know every single thing about congenital rubella syndrome. It's part of the screening that we do in OB, and really if we did it correctly, we would be screening healthy young women who are thinking about getting pregnant. Because once you're pregnant, can you give them the vaccine?
No.
Why?
Live.
Because it's live, right? So by that point, you're pregnant and it's already too late, okay? Don't worry about the awareness stuff. I just got really excited for some reason. So this one is another one of those respiratory that's going to invade those systems, then start spreading from that nasopharyngeal secretion, so very, very similar. And the specific thing that I need you to know with this is that it is most concerning and most highly transferable in that first trimester of pregnancy. So that is going to matter. There are some things that affect second trimester, there's some things that affect a third trimester. This specific one is the first trimester of pregnancy. So within those first, usually really 13 weeks, can be very, very bad. Really after 16 weeks, they're kind of in the clear because some of the processes that this is going to affect already happened. So you don't have to worry about that as much. So if it's postnatal, so these are the ones that really aren't that bad, right? So this is the ones, this is not the ones that you're gonna get tested on the pants, I'll just tell you. You might get tested here, but this is not what the pants is going to focus on. But just so that you know, it's going to be that same fever and a rash in a child. Fever and a rash in a child. Another long incubation period, so a lot of these have that. And it's gonna be pretty minor. They look like all the rest of them. Sore throat, headache, tired, really nothing to write home about. The pattern of their lymphadenopathy is a little bit more interesting. It's a little bit more rare to see suboccipital and postauricular nodes that are prominent in a child those typically go with different types of viral infections. So if you see post-auricular, you're thinking it's something probably viral and specific, so EBV is classic for that. Rubella is another one. If you see anterior, more likely that it's going to be something bacterial, strep related, if those are super, super prominent. What's in reality more likely with kids is that everything's inflamed and you just start feeling lymph nodes everywhere. But if they're specifically prominent, suboccipital, post-auricular, that's when you would start thinking something rubella. This rash then starts that pattern, not at the hairline, but still on the face and works its way down. So the pattern is a little bit different, but the fading is a little different now too. Instead of going back from the bottom and then resolving, starts at the face, works its way down, and then starts resolving from the face and works its way down. So a little bit different pattern there. Some of them don't even have a rash, so that's one of the things that you'll see that's a little different. And instead of Koplik spots, this time you'll have Forsheimer spots. And these ones really look like petechial hemorrhages and petechial rashes on the back of the palate. However, if you said, oh my gosh, that's a Forsheimer spot, I know that's rubella, it doesn't quite work like that. It's not the exact same as a Koplik spot, it's not pathognomonic. Because what else do you see these petechial rashes in the back of the palate with? Strep, correct. Yep, so strep pharyngitis can do this exact same thing. So if you were only given petechial rash on the back of the throat, or the oral pharynx, or on the palate, your differential should be, is this strep pharyngitis, or is this rubella? Let me look at that vaccination status. Let's look at this. So if I just were to give you this picture of the kid with the rash, you'd be like, measles, rubella? Don't know what that is. Plus, now I give you the petechial rashes with a specific pattern. Now you're like, we're trying to do rubella. IgM testing can be done for this. This is if it's an active infection. If anyone has, I really struggled for whatever reason remembering IgMs versus IgGs. I can't believe I'm about to tell you guys this. But I always remembered IgM is a really big antibody as opposed to IgG. That's why IgGs can fit places. But this really big one is here right now. Right now, right? So it's the diagnosis that's happening right now, as opposed to G. So I do not know how I passed school some of the time. You can do PCRs. Again, it's really not going to change your management at all, but some of the time it's really helpful to confirm a diagnosis because, again, rubella, much like measles, is reportable. So it's another one that if you see it, you have to tell somebody and let them know. Okay, so this is the one that I need you to star highlight. Know everything there is to know about this and say. Because this is also, I'm going to nerd out on you guys for a little bit here, so just buckle up. I'm rare form today. So, congenital rubella syndrome. So, this is when mom either was never vaccinated or mom doesn't have antibodies that are stable. Rubella antibodies are not as stable as measles. Okay? So now her antibodies have waned, she is exposed to rubella, and she contracts rubella in that first trimester. It is spread transplacentally to the baby during developmental structures. Now, the reason that is called blueberry baby is because this messes up a whole lot of processes embryologically. So it goes into your bone marrow, it's one of the things that it does, and so because of that, the baby has all of these little spots all over them. It's a really interesting compensatory mechanism. This is not a rash at all. This is extramedullary hematopoiesis, meaning that the bone marrow isn't able to keep up, so the baby's adaptive response is to have little amounts of blood being made in the skin. So extramedullary hematopoiesis is what makes those little blueberry spots. And so it's why they're called blueberry babies, blueberry muffin babies. Right? So not a rash, extramedullary hematopoiesis. The other thing that it will do, because depending on where this is, and this is not necessarily what you guys need to know, but just to help you understand some of it, it will inhibit in the cells, the actin assemblies, remember if you were talking about all the different parts of that, it inhibits that actin. And so what happens with that is the structures, some of them do not form correctly. So one of those structures that doesn't form correctly is the ductus arteriosus. And so if you don't have actin that's going to be able to close that as soon as they are born, now they have a persistent ductus arteriosus. So they have a PDA because in that first trimester, it didn't form correctly in that assembly of actin. The other thing that doesn't form correctly is the temporal bone. So the temporal bone, you can end up seeing some sensorineural hearing loss as a result of this. So that's one of the things. However, because it will also upregulate other things, think about the extramedullary hematopoiesis, it will upregulate mitosis and some other things because of those pro-inflammatory, pro-cytokine response. And so you will see excess of other things. So you saw actin didn't work right, so some stuff didn't form. Now other stuff does form. And so that extra mitosis process results in these early cataracts formation in the eyes. So you see the temporal bone, the sensorineural hearing loss and deafness, and a PDA because some stuff didn't form. And you see cataracts and the blueberry stuff because extra stuff did form. Right? This all happens because that first trimester placental transfer of rubella. So this is something that ideally we never see because we have all of our childbearing women vaccinated. Right? So in theory, 100% preventable. So know that one inside and out. It's like bilirubin. I just love it. So, and it's just high testing fodder. They usually on the pants. They usually will test PDAs. Just of note. No specific treatment again for this because it is virus, so immunization is going to be that key. There's a little bit of a smaller window, so in theory you could give post-exposure prophylaxis, but because again it's kind of that measles-like, not as contagious, a little bit harder to get here. And since it's again a live vaccine, unable to give to those pregnant women. So just very, very similar to measles in that. Mumps. For our last one, and really I know this is in zero order and this actually doesn't have an example with it, but it felt weird to just be like, blank R, right? Like to not do the other M for MMR. So we're just going to hit it very briefly for mumps. So for mumps, again, self-limited. This is, I think, kind of interesting. I don't know if I've heard about it. But this specific virus goes to places that excrete things. So particularly your carotids, keratitis, to the testicles, to the pancreas. Anywhere where you have exos and secretions is going to affect that. What it will do, the virus itself will go in, cause small little areas of infarct and necrosis, and that is what is so painful. It is the necrosis itself that is what is hurting the patient so badly. So, because the parotid glands are involved, again, hydration can be really, really difficult for these kids because it hurts. It hurts just from necrosing, it hurts when they drink, it hurts any kind of salivation. So one thing to be aware of. Oh man, I did put all of that in there. Those are the places, the secretion ones. The thing that to know about mumps that they will, they like to test is these long-term complications. The parotid gland, because it secretes so much and all the time when you're eating, when you're drinking, it usually clears okay. Same with the pancreas. If you have a pre-pubertal boy, the testicles are not responding that same way, and so you can see a long-term problem from this orchitis that can result in infertility in older boys and men. So one of the things that you see. Same with the necrosis and the infarcts there. This is a picture from the top of Nelson's textbook, which I know you guys all read every night, just to go over all of this. But if I were just to see that picture on an exam, I am, of that top one, I'm really not getting their significant parotid swelling in this child. I might think, oh, that's a little punchy child. Oh, there's a little bit of maybe some stuff going on. They don't maybe look super happy, but I'm really not getting this profound parotid swelling. The bottom picture is, or the bottom two pictures, is the same patient. When he's on the left over here, that is what he looks at baseline. The right is what he looks like when he has mumps, okay? So if you have a patient, just kind of helpful thing to do, if you have a patient where the parents or the patient, whoever, is saying, well, don't you see how bad this eyelid swelling is, this ankle swelling is, this rash is, one of the things to do is, can I see a picture of you normal? Like, what's your baseline look like? Because I might have thought that this person was just obese, right? Especially if there's a virtual appointment, I might not really see that he looks completely different. This profound carotid swelling. So that's one of the things that you're going to see, and then again, orchitis is the most common long-term complication. Some GI stuff, again, because the pancreas is involved, but a little less common with that. You can do a clinical diagnosis again for mumps. If you want to, with that parotid swelling, again, your PCRs, your IgGs. And amylase could be super helpful here. This would be one indication where your amylase would be high and your lipase would not be high. Or actually, if the pancreas is involved, it could be, so scratch that. It could be either, depending on what symptoms this patient has, but specifically with the parotid swelling that you see in children, the amylase would be pretty high for that. Your differential is going to be any other thing that causes parotitis, could be autoimmune. Autoimmune goes after the parotid gland specifically. You would see that less in younger children, but certainly if you had a teenager, that would be something that would be higher on your differential. No antiviral therapies are needed, supportive care and time, again, fertility is what you're gonna think about for those long-term complications. Again, it's that last M of your MMR, so the reason we threw it in there. But back to our exanthems. We are now at fifth disease. So what was 4? Staph. And really there's a whole lot of controversy on like, is that even, what was it Staph aureus? Is it something else? Is it strep? Is it staph? Is it all kinds of things? Yes, ma'am.
Mumps is not reportable.
Mumps, that's a good question. I will look that up. I don't believe mumps is reportable though. Let me write it down. Okay, so first disease was what? Measles. Second? Scarlet fever. Third? Rubella. Fourth? Maybe staph. Historically, yes. Which takes us to fifth disease. So fifth disease is one that they will try to get you because they will use all the different names. So what I also need you to write in right there is that I could use fifth disease, I could use erythema infectiosum, or I could use parvo. And I could use those interchangeably. And that's what the PANTS loves to do, is to use, you'll be like, I got it. I got erythema infectiosum, I got it. And then they'll use one of the different names. Right? So for this specific one, be able to go back and forth between all three of the names. Again, it's caused by parvo. And what I need you to know is that we see this all the time in kids. All the time. The slap cheek rash of parvo. So they come with fever and a rash. The rash is the slap cheek rash. We'll talk about it a little bit more. Super benign for most kids. You're like, this is a dime a dozen. This is parvo. They got it. No big deal. Their puppies probably had it. Now they have it. Right? Something like that. The problem is that this particular virus goes after the baby red blood cells, your progenitor red blood cells. And that's a big deal if you already have something wrong with your red blood cells. So number one, if you can't make them correctly, problem. Number two, if you destroy them quicker, that's a problem. You can't make them. Because you're going to have a transient aplastic crisis. So while your body is recovering from this, you'll have about 7 to 10 days where functionally the factory is shut down. So your red blood cell factory is just kind of like, woe is me, and nothing happens. So for you and I, who are healthy, for most young kids, totally fine. They'll pick back up, the factory will turn on in a couple weeks, we are good to go. If you have sickle cell, if you have spherocytosis, if you have thalassemia, if you have anything that is going to cause more breakdown or doesn't build it correctly, now you're in a world of hurt because you can't accommodate for those 7 to 10 days of aplastic crisis. The other thing is, here's another pregnancy-related one. If you're in pregnancy and you need a lot of these red blood cells and you need a ton of that oxygen and to prevent fetal anemia while this child is growing in utero, and suddenly you have 10 days of nothing, you have put this child at risk for death and fetalis hydrops or hydrops fetalis. Usually it comes on as the weather is warming up a little bit again, and respiratory and blood could be one of these things. So this is one of the things that is screened for with blood protocols and transfusion protocols. Don't want to just give this to somebody. But the thing really that I need you to take away from this is if you see fever and a rash and they give you something else with those red blood cells, go to Parvo. They're giving you that for a reason. So if you're like fever and a rash plus literally anything with a red blood cell, that's what they're trying to go for. Incubation period, pretty standard, up to about 2 weeks. I guess could go up to 3. Again, most of the time, it's pretty benign. Fever, achy, rash, headaches, you are at pretty normal. Nothing to write home about. In the adolescent age, you can see a little bit more of some joint involvement and some GI involvement. Again, really nothing to write home about if they are healthy at baseline. The specific rash that you will see is the slapped cheeks. So how is this different than, you're like, wait a second. We had a child abuse lecture. If I saw this, I would be concerned about that. Number 1, I'm not seeing a pattern. Number 2, I'm seeing it in both cheeks. Number 3, it spares the mouth completely. So it will always have this circumoral pallor, and it's really not even pallor, it's that it's not part of the mouth. So the whole mouth is spared. So very predictable in how it looks. That's stage 1. Stage 2 then is it basically goes everywhere. So this whole trunkal rash. So it started with their cheeks and now it's on their trunk. So that's the first part. Cheeks, then trunk. And it is this maculopapular, so some is raised, some is flat. Just kind of looks this diffuse pattern. Stage 3 then, you get some central clearing. So each one of those little individual maculopapular entities, I actually like this picture better. See where the central clearing, you can see in the center of each one of those, there's a little bit of that clearing. And it starts to kind of coalesce together and look lacy. So we talk about lacy rashes. If any of your grandmas, aunts, whoever, kind of made those lacy little doilies that everything connects. It looks like that. That's why we call it that. This can last a long time. So if you're like, I saw the slapped cheeks, the thing to tell these parents, these patients, or if it is an adult, is that you are likely going to have this for several weeks. So you will see that. This is the first one of these that we've seen now. It's pruritic. So this is different. When they get to stage 3, so it wasn't itchy when they had a slapped cheek, it wasn't itchy when it went to their trunk, but now in stage 3, is it starting to fade and kind of peel away, very, very, very itchy. And what's going to make it peel away? Well, areas of high friction. And so any area where you're going to see that, so lines with elastic, any place with their folding, on the arms, necklines, anywhere like that is going to specifically peel even more, desquamate even more. How do you know what this is not then? Because you're like, wow, there's a lot of stages, it's kind of everywhere. This pattern is all over the place, it's itchy, it fades, it spares the palms and soles. So look for that specifically in these test questions. No palms, no soles. And this is that complication then. So for those 10 days, now you have this aplastic crisis. Again, it does not affect a healthy individual. It does not affect 90% of your kids, 99% of your kids. It's going to get the ones that have an underlying red blood cell issue. So that's what you are looking for. If you have that, they're going to give you, and in real life, they will come with a significantly increased presentation where they look sick. So kids with parvo come in, they look like they don't feel good. They're febrile and they, are achy, so they don't look like they're doing great, but they don't look toxic. These kids, when they're in an aplastic crisis, they come in looking significantly sick. True lethargy, true pallor, tachypnea, they're pretty toxic, so they need intervention pretty quick. One of the things to look for if they give you labs is that aplastic crisis, and so you would see their hemoglobin, if they already have red blood cell issues, their hemoglobin is low, and so you would expect if the hemoglobin is low, that the bone marrow is pushing things out. And so you would see your reticulocytes in your babies be really high. When you have this aplastic crisis, your hemoglobin is low, and so is your reticulocyte, because that factory is shut down. We will finish this and then we will take a break. So, biggest thing then is that was category 1, is your people with red blood cell issues. Category 2, your pregnant women. So now you're pregnant women, and this one, different than rubella, now your second trimester. The second trimester is because now all of your organs have formed, so it's different than rubella. All of your organs are formed, and now you need a ton of red blood cells and oxygen to make everything grow. And so that's where you see think back from block 1, no flow, no grow. And so this would be a time where you see no flow, thus you're not getting growth. Then you see the child that does not make it. So second trimester, fetal anemia, because the fetus will get this same thing. And so really, really bad for a baby. The way I've seen this one asked on board exams is usually a daycare worker or a nanny and is watching these children. The child is diagnosed with a slapped cheek rash. What is your concern for, then the daycare worker finds out she's pregnant. What are you concerned for? And so the answer is a hydrops. You can do this by a clinical diagnosis, so really your labs aren't going to help you that much. You can get your IgMs, you can get your PCRs. This one is not necessary, this is not reportable. We see it frequently enough. Again, most of the time you're just going to keep them hydrated and comfortable. The ones that you are going to worry about, pregnant women and your underlying red blood cell issues, which those ones you're going to have to say, do I need to give this person a transfusion for the aplastic crisis? And then if it's severe enough, do I need to give IVIG to really combat this? That's a good place. Let's take a break till 11:02, and we'll come back and pick it back up. Now you are the providers, go forth with that knowledge. Okay, so we're jumping into now roseola, or 6th disease. And this one can make you look like a wizard. I'm going to just tell you that one. So this will make you look brilliant. But this is also the one that people mess up the most, and I'll tell you why. So again, I need you to be able to go between roseola, exanthum subitum, and 6th disease. I've seen board exams use all 3 of those. So how do you remember that this is actually 6th disease and what causes it? Well, the most common is human herpesvirus 6. So HHV6 is also 6th disease in that old numbering system. So that's just how I remember that one. Usually this is smaller kids, so they have learned to sit up, but they are not mobile yet. So this is, when you put this in your head, I need you to think under 2, but really think baby. So if you see a test question that has an 8-month-old, 9-month-old, 7-month-old, somewhere in there, it's typically going to be how it is asked. Again, good protection up to about 6 months. So that's where most antibodies are going to be, because they have about 6 months protection. And again, from your respiratory or your saliva. So this one is super interesting. So think back to our fever lecture, where you have a child with the hands, right? Day 1 of fever, day 2, day 3. 3 is going to peak, 4, 5, you should start seeing it go away, right? How long was it before we called it fever of unknown origin? 8 days, right? And so that typical hand pattern with that fever of unknown origin of 8 days kind of plays a really big factor here. So in this one, the child will come in, or the child will have relatively high fevers. This is again one that is usually above 103, just in practice. So it's 103, 104. Usually not up into 105 range. If you saw that, I need you to be thinking measles in an unvaccinated kiddo. but really think it stays high, 103, 104. Responds to Tylenol and Motrin, but just stays way up there. And it's that way for 3 to 5 days pretty consecutively with nothing else. Right? So now we've talked about this hand where we're like, so now you're in the urgent care, you're in an ER, you're in a clinic, and these families are bringing you a kid. And you're like, let's look for an ear infection. There's no ear infection. Let's look for a UTI. There's no UTI. Let's look for a skin rash. There's no skin rash. Let's look for strep. Oh wait, we learned that strep really doesn't happen under the age of 3. I have no idea what this is and why they're fevering, so let's throw some amoxicillin at it. Wrong. I swear on all things good and holy that I will come do something. Because this is what typically happens, is that people get nervous because they're like, it's gotta be a fever from something. Don't know what it is, but it's gotta be infectious, so I'm gonna give amoxicillin because that covers most things, right? So 3 to 5 days of this pretty high fever with nothing else. So that is going to be fever without a source, or fever without a focus. So this is a perfect example of that. Then, as soon as the fever breaks, that could be day 3, that could be day 4, that could be day 5. As soon as the fever breaks, this child develops this full body maculopapular rash. There's no more fever, head to toe, trunk and out. So it starts on their belly and then works its way out. So it's like a sunburst. It's like the fever has gone, hey, and it spreads out, right? So that's how it's doing. They can have a few other little respiratory symptoms after that. And because the fevers are so high, sometimes you'll see some febrile seizures with that. But what I need you to think, this is the fever that rashes, okay? So what I'm going to tell you is what happens over and over and over, and this is what you guys are going to deal with as adult providers. Somebody had 6 disease. They had these high fevers. They go in on day 3 or 4. They get amoxicillin completely unnecessarily. They take a dose or 2 of amoxicillin. The fever breaks. Now they have a full body rash. Somebody who didn't know this says, you must be allergic to amoxicillin and penicillin. We should put that in your record that you can no longer have penicillins. Yay. Now you have an active duty member. You have an adult patient. You yourself are like, oh, do I actually have a penicillin allergy? I have no idea. And now you've taken out that whole class of antibiotics that you're going to use. So, again, do not treat something with amoxicillin or a penicillin in a child that you do not know what you're treating. You are not a vending machine as a provider. You are not forced to treat them with anything. If there is nothing to treat, for the love of Pete, don't do it, okay? For this specific reason. At least give yourself the chance to look like a wizard. Because what you're going to say is, there's nothing to treat. The things that we would treat for this child would be with antibiotics, would be ear infections, would be pneumonias, would be urinary tract infections. And we don't have any of those right now. So why don't we make a follow-up appointment for day 6? And if you're day 6 and you're still having fevers, then we'll talk about the rest of the things. If you get a rash, on a full body rash that starts on the belly, on that day 4 or 5, then I know exactly what it is. And then you look like a wizard. And you save this child a lifetime of penicillin allergy. I am off my soapbox now. I hope you remember 6 disease. Clinical diagnosis, that's the exact same pattern. If you really wanted to know what it was, the gold standard to test her would be a viral culture. If you do a viral culture, I don't know why you did it. I guess you could, but it's not going to change your management here. Same supportive care. If you are immunocompromised, you could consider an antiviral. That is not standard. We are not standardly giving kids these antivirals. These kids do excellent, so this is your chance to either be a wizard and look like a brilliant provider, or mess this child up forever. No choice. Chickenpox. How many in this room had chickenpox? Yeah, it's starting to get less and less, right? Because vaccination came out about 1995. So for the youngins in the room, a lot of you guys were vaccinated against this. The rest of us got it when we got it. So varicella, chickenpox. As a reminder, for your older population, this is going to be zoster when they are going into those dorsal root ganglia. So kind of hides out into there and can come back out. Can come back out in children as well. So even vaccinated children can have a zoster presentation. This one's airborne. So that's a little bit different. So there are those, that's one difference that you do see from those respiratory secretions. Long incubation period again. The biggest question, if we start seeing this again, will be, when can this kid go back to school? When can they go back to daycare? When can they go back to their sports? When can they do this? Your answer is when every lesion is crusted over. That is when they can go back. When every lesion is crusted over. That means they are no longer infectious because they are no longer making new lesions. They can go back then. Just some interesting facts, again, 1995, when it happens, when it comes on. So someday, if you were the ones like me, and you are coming back here and teaching ICAP, you'll be like, does anyone have chickenpox in this room? Or we'll have a resurgence and everyone will have chickenpox. So that's it, prodromal period again, that looks like everything else. Fever and the start of a rash. When we say anorexia, so I don't know if you've gotten this from any other medical terminology, we use this in pediatrics a lot. Anorexia is not anorexia nervosa. Anorexia just means lack of appetite. So you have true anorexia in these kids where they do not want to eat. They are tired, their heads hurt, they have not started the rash yet. Can get another high temperatures. This could be one of those that you really do see that. It's a little bit more brief than some of the other ones. And then the rash starts. This is another one that starts on the trunk and spreads out. Varicella is going to do that. And you will see all the different lesions simultaneously. So you are going to see some that are vesicular, some that are pustular, some that have opened and ulcerated. You're going to see all of the different stages at the same time. If you see something in a patient and all the lesions are at the same stage, you should pucker because that is what?
Smallpox.
That's smallpox. We have been hit with bioterrorism and that is reportable. You should tell somebody that, right? You should tell somebody if you see varicella too because most people haven't seen it. But all of the lesions at the different stages are going to be there simultaneously. This one, you have had it, if you haven't, profoundly pruritic. So this is not just a little itchy like we saw in parvo over those areas of friction. These are highly, highly pruritic. My favorite show of all times is Friends. There's an episode where Phoebe and her Navy boyfriend end up with adult chickenpox and they're super, super, super itchy. That's what we will typically see, is the kids are just so darn itchy from this. The rash themselves, so it is a papule, means it is raised. So a lot of these we see maculopapular. These ones are raised. They are non-umbilicated. We'll talk about different ones in the derm lecture that is also on this test that have a little donut hole in them. They're umbilicated, so they're non-umbilicated. And its base is very, very red. So the kind of classic is the dewdrops on a rose petal or whatever, and you're like, sure. It's a papule on an erythematous base, is really what that is. Can be on the mucous membranes. The fluid inside will start clear, so it means it's an earlier lesion, and then it will go cloudy, it's a little bit later lesion, then it will ulcerate, and then it will start to crust over. So once they're all crusting over, that is when they can go back. They will keep popping up for about a week until they don't. It can present very differently. The younger you are, the better off that you often do with this presentation. So you see a little bit, a child who doesn't feel great. You might have those ulcerations and they're super itchy and they don't want to drink. Or you could have this baby that is totally and completely happy in his oatmeal bath. Right? You can see all kinds of different presentations with this. This looks like it hurts and it's itchy. So if you're seeing the different stages, so you see the erythematous base, you see it looks like almost like a drop of water on some of those. That's the dewdrop on the rose petal look. And you can see some of them have ulcerated, some of them are open, some of them are still kind of bubbled and bulla. That is what you are looking for. Different stages, erythematous base with what looks like almost like a water drop on top. The complications. This is where they test you. So this is what you specifically will need to know. Because chickenpox on its own, not that interesting. Maybe some of the lesions and different stages versus smallpox, sure. But this is what's going to get them. So think back to that Friends episode where they are so itchy, right? If you can't even get an adult to not scratch, you're trying to reason with a 4-year-old. You can't scratch this thing that is profoundly itchy. right? So they are going to scratch anyway, because that's just how humans do. So your biggest and most frequent secondary complication is some sort of skin infection. So this could look like an impetigo right under their nose. This could look like a big, massive cellulitic infection. This could look like scalded skin syndrome. This could look like necrotizing fasciitis. Depending on what they get in to that skin from that secondary skin infection from scratching is going to be the most common outcome. Varicella is also known for its profound, really negative side effects if you're immunocompromised. So varicella pneumonia is one that you see, specifically in kids that have a leukemia or an underlying cancer diagnosis or immunocompromised. And then think back to your fever lecture. Encephalitis, varicella encephalitis was another one. So when you see this, big, bad, ugly complications, so that is one of the reasons we vaccinate, right? It's rare, but in residency, the first time I saw a kid with a secondary neck fash from itching, from varicella, from chickenpox, you're like, I think we should vaccinate. I see why we do this now. This is also the one, and the reason that the boards love this is because the combination of aspirin and varicella in the right child is what produces Reye syndrome, or Reye syndrome, depends on how you want to say it. So this one, you need all of those, you need both things. You need aspirin and you need varicella. And so because it used to be so ubiquitous and everybody had chickenpox, we just said we're going to avoid aspirin. So probably now that people are vaccinated, we could change that, but it has gotten into the standard practice, and so we just, in general, avoid aspirin in children for that specific reason. So no salicylates. For your treatment, it is again symptomatic. Non-aspirin antipruritics, so that's one reason, one way that they'll get you sometimes. And typically, unless you are digging into this, it is a superficial skin infection. So if you do see this and the family says, is this going to scar? You say, it's not going to scar from the lesions themselves, but the scratching might scar. So that's typically what you will see. If they are severe, high risk for a severe outcome, this is when you are going to use antivirals. So you say, Dr. Klein, what does that mean? They're high risk. Well, I'm glad you asked, right? So if you're older, so if you're an adolescent, if you had some underlying and really severe chronic pulmonary, this is not the child that has exercise-induced asthma. This is like, we have bronchopulmonary dysplasia, bronchiectasis, or some other really chronic underlying pulmonary disease. Some debate over if you need inhaled or chronic steroid use. So I'm not going to try to trick you with that one, but just know it's one of the guidelines with steroids. And then if you are on long-term aspirin therapy, so let's think about like Kawasaki's disease, or if there's another reason that you are on this long-term aspirin therapy, and you now have varicella, could be something to think about. This is one where your vaccination is not perfect, so they could still contract this, but still have secondary zoster. So this is one, again, that we give at the 12-month mark. It's a live vaccine, and again, with MMRV. The big thing to know with varicella in children is that if you have an immunocompromised child who gets a primary varicella, it's very, very bad. So if you are doing, if you're in a children's hospital, if you have a child who has specifically leukemias or any kind of immunosuppression like that, they tend to do very, very poorly if they obtain it. So kind of something to be aware of there. The other thing that is really interesting that having to do with pediatrics is that you want to prevent the newborn from contracting this. And so this is a very specific situation that doesn't come up often, but your boards love this. My boards love this, I guess, specifically. But what an indication to avoid contact with mother, avoid breastfeeding with mother would be if she is diagnosed with primary varicella, primary, meaning she's never had chickenpox and now she's primary varicella, 5 days or 2 days after delivery. There's that leak in there. The highest risk for neonatal varicella that can be very, very deadly. The other thing that you saw back from block 1 is if you had varicella or you had a zoster that occurred directly over the breast. That was one of those contraindications for breastfeeding as well. Again, you're gonna get asked, so over and over and over, you see this, when can they go back to school? They're driving me crazy. When everything is crusted over. If you're in the hospital with an immunocompromised patient, they need an airborne room, because it is spread airborne. And that vaccine is also obviously recommended for all those age groups. Zoster does happen in children, so if you're thinking, oh no, that's an adult thing. Oh no, it is also a child thing. We're starting to see that more and more. So the problem, and when you get this transferred, is if somebody is in contact with the direct lesions. So if someone in this room has zoster right now, that sucks. I am so sorry to hear that. However, unless we are rubbing up with this, not going to transfer. What do children like to do? They like to be all up in their space. So grandparents, parents, anybody who has that, there's that direct contact with lesions can spread to the child. Zoster in a kid is going to look very, very similar, so it's still going to follow that dermatomal pattern. It's still going to be very, very painful, and it will still have that same crusting and regional lymphadenopathy that you see with that. So it's going to look very, very, very similar. And I will say one of the things that will bring this out is stressful situations. I think the most common thing that I have seen with zoster in a true pediatric patient is in your late teen stage. So think about who you're going to see. 17, 18, 19 years old, just got out of boot camp, first time away from mom. I'm really stressed, and now I'm coming in with this, it's acute and sharp little band of back pain, chest pain, something like that. Put this on your differential, because that is how I've seen it most often in teenagers, actually. A reminder that if it goes after cranial nerve 7, it's Ramsay-Hunt syndrome. That can specifically affect the face. And same with adults. Postherpetic neuralgia can be a thing. Less common than adults, but this is why you want to treat and why you want to prevent this for kids. This is just my attempt to be welcoming to adults in the world, not just for kids. Plug for your OSCEs, plug for you as providers. One of your prevention things should be the zoster vaccine at 50. So if you're thinking, I got my mammo, check. We got the colonoscopy, check. We got smoking cessation, check. Add zoster on there at 50, because it's going to prevent things for the pediatric population. It's going to prevent things for themselves. It's going to save you a lot of appointments for all kinds of things, and it's painful. So you're trying to help your patient. Speaking of things that hurt, so has anyone in this room had hand, foot, mouth as an adult? How did that go?
It sucked.
It was terrible.
It was terrible. Couldn't walk, couldn't do anything.
How well did you want to eat? Did you get anything in your mouth?
Actually, my mouth was fine. It was just the
Was
bottoms of my teeth.
But it hurt, right?
Oh yeah, it was terrible.
So this hurts. So I will say hand, foot, mouth should be named hand, foot, mouth, butt. It's always going to occur on the butt. Not always, but it really does. Hand, foot, mouth, butt. It does not ulcerate on the butt like the rest of them, but it should be named hand, foot, mouth, butt. So this one is a Coxsackie virus. So when I think about this, I think it's a ClinCor case, but it's going, and we'll talk about that actually with complications, so never mind, we'll get to that in a minute. So Coxsackie virus, that's going to be your underlying etiology. This is a fecal-oral transmission. So this is the first one of those exanthems that we've seen fecal-oral. So this is one of those where you're like, kids are disgusting. You think about fecal-oral. Yuck, right? That's how they're getting this. Short incubation period, so that's different from the other ones. We saw those ones were long incubation periods. Now it's very, very short. And now you have this vesiculopapular rash. So we haven't really seen much of those. These vesicles that ulcerate. This is the first time we've really seen that on the palms and soles. Most of the time, those areas are spared. When you see something on the palms, the soles, the mouth, and the butt, hand, foot, mouth, butt. Just add that to you. And the diaper area doesn't usually have the vesicles. The other thing about this one, it's not pruritic. They don't care about it. This one is very, very painful. So it's painful to adults when they get it. It's very, very painful to children. So now you have pain in your hands and feet, in your mouth, in your bottom. How well do you want to go to the bathroom? How well do you want to eat? How well do you want to walk? You do not. Because the child, this one often just shuts these kids down. And the entire daycare, the entire house, everyone usually gets this because of the short incubation period. Hands, feet, mouth, butt. Vesicles. They can have some petechiae in the back of the palate, but you will see these ulcerations, right? So if I just saw petechiae, what are my two differentials? Strep and rubella. Yes, correct. If I see petechiae but with ulcerations, that's when I start thinking it's more of a hand, foot, mouth skin. Again, it can look different things, so the vesicles will come in different shapes and sizes, the mouth will look different, so it will have various presentation. And your biggest thing is going to be pain control and hydration. So yes, we've talked about antipyretics and hydration. This one specifically, because it is painful, this is one where kids will circle that drain. And they're just like, I'm not drinking, I am not eating, I am not doing this at all. So getting them as hydrated as possible and as comfortable as possible is going to be super, super important. So we talked about those doses of ibuprofen and acetaminophen. What if they're like, I'm not taking that orally? You have a 2-year-old that's just like,
Suppository Tylenol?
Suppository Tylenol, absolutely. So this is a perfect indication to use a suppository to get those children comfortable and calm so they're likely to drink. Perfect, yep. The other thing about this, yes ma'am?
Yeah, could we throw some like the Orajel, like the gummy Orajel at their mouth a little bit to try and convince them before we go to the suppository?
That's a great question. Orajel isn't going to do as much anymore. They took out the benzocaine from that. It's causing some antiarrhythmias, so it's not doing as much. What I typically do is a combination of magic mouthwash. So it's Maalox, Benadryl, makes them a little sleepy, and viscous lidocaine. So it's a 1-to-1. Depending on where you are, the pharmacist will have to compound it for you. So some places won't want to do it, but 1 part Maalox, 1 part Benadryl, 1 part viscous lidocaine. Good question. Where are we? Oh, yeah, this one is also different because it sheds for 6 weeks. So when people are like, when can the kids go back to daycare? We as pediatricians and as providers are like, when the fever's gone. Please know that physiologically, that is incorrect. Ideally, you say, you should stay home for 6 weeks. Could you imagine? No one would ever go anywhere if you actually held people home for 6 weeks. Right? Because that's how long this virus is going to shed and fecal oral transmission is going to occur. So I want you to know, that you will now know, and I know, that the arbitrary return to daycare after 24 hours of fever is totally arbitrary, right? We should be going on 6 weeks of shedding. But again, nobody would do anything. So we have collectively as providers said, once the fever breaks, your transmission is likely much less. The thing that I need you to note, so if a adult has hand, foot, mouth, if you see a child, it's going to be one of the weirdest things, and you are going to prevent yourself from mommy call or an ER trip or them totally freaking out. One of the things that happens after hand, foot, mouth is that your fingernails can fall off. So your fingernails and toenails can just fall off on a child or on an adult. Okay, so if you're thinking, and it can be weeks later, right? So if you're like, you wake up and all of a sudden your fingernails have fallen out, that, I guarantee you, is a time where the family's gonna be like, oh my God, this child is breaking, right? If you tell them up front, this is hand, foot, mouth, this is the typical presentation, I don't want you to be scared if the fingernails fall out because it affects that epithelial layer, right? Then you've already prevented it, you again look like a wizard. Okay. Oh, we're back to scarlet fever, what number was that? I should probably put that in the right place. I don't know why I didn't go do that. Yep, second disease. You guys have got it. Maybe I was trying to confuse. I don't know. What did I do? This one's a group A strep. So this is your specific strand of your group A strep that is causing this. So we will again talk more about strep when we get to it. The reason that we're talking about it, yes, it's part of that numbering system, but it has this specific strand has that associated sandpaper-like rash with it. So if your commanders or anyone are like, can you do this with a virtual appointment? You can say, absolutely cannot, because I need to feel this rash. It truly feels like the skin is that fine sandpaper. So if you've ever felt a child's skin is very soft, baby soft, literally it's called that, baby soft, right? This on a child feels like sandpaper. It's just rough and erythematous, kind of everywhere. The best thing to describe it, it looks like a sunburn that turned sandpaper. If that's what it looks like, that's what it feels like. The rest of your findings are going to be the exact same as your group A strep and your Centor criteria that I know that you guys learned. And then we will start, this is the first time we start seeing it, and we will hit it several times. If you have group A strep, not your other streps, group A strep, you can use low dose amoxicillin because it is so susceptible to it. So we'll talk about all kinds of other things that we're going to use high dose amoxicillin for, but anytime you see anything that is a group A strep, your low dose amoxicillin is 50 mg per kid per day divided BID. You will need to know that dose. Okay? Low dose, group A strep, 50 mg per day. This one though, because of that rash, because of how it looks with the Centor criteria, your differential is going to be Kawasaki. So we will talk about Kawasaki when we do cardiovascular. But one of the things, so yes, it has a rash. Yes, it has that pharyngitis. Yes, it has your lymphadenopathy. Yes, it can have a white tongue turned strawberry tongue. So those things are going to look very similar to Kawasaki's. I didn't really hit that very hard. It's because it's in the cardio lecture. The other one now is herpes. So we have hit herpes from various different ways. We're looking at this in the exanthem and infectious disease lecture. This is going to be that direct contact on mucosal surfaces. So we haven't had that as much yet, other than those zoster that we had. The rest of them were those respiratory secretions. Now we're looking at direct contact. Same as adults, you can have the primary infection and then the latent infection, and you can have one or two. So it's the same for kids. You can have HSV1 or HSV2. Typically oral for one, genital for two, can see other ones. This one is the big, bad, ugly one. If you even think to yourself, maybe this baby came in contact with herpes, add acyclovir. The outcomes are absolutely devastating. So, new neonatal herpes, add your acyclovir. You have a history in the mom. In real life, what I've seen the most of this is they will use fetal scalp monitoring. So they will put a little monitor under the skin of the on the fetus as labor is occurring, and then the baby is passing through the canal and comes into contact. And so that is typically how I've seen the transmission. So pediatricians really don't like fetal scalp monitors for that reason, because we're like, but what about these cases? And OB's like, well, it's irrelevant if the baby doesn't get here alive. Right? So peds and OB lovingly have this rivalry. But in real life, or when you're under rotations and you see the fetal scalp monitors, know that somewhere a pediatrician is cringing internally. And what that risk-benefit ratio is. It's still a risk to the baby. You can get the cold sores, herpes labialis, as we are going to call this from here on out. Kids are going to get this as well. It's the same thing. When they get stressed, first day of school, going to summer camp, soccer tournaments, all of those things. It's the same type of thing as when they come out. The difference in that labialis versus gingivostomatitis is that border involved. So make sure if you see a picture on anything, on your pants or on any kind of test, is the vermilion border involved, because that changes your diagnosis. Labialis versus gingivostomatitis. Think back to block 1. We talked about, hey, why are we checking for skin infections? Most of you, this one, are they going to be coming into contact? Do they have something transmissible to somebody else, such as wrestlers, where herpes glandulotorium could be something? So specifically for anything where you have that tight contact, so if you see a question that has 15-year-old males on the wrestling team, you should be thinking, are they about to ask me about herpes or cauliflower ear? Like, it's gonna be one of the two, right? They're gonna ask you something where there's contact related to this. That should be something to be aware of in those sports physicals. The other thing that's going to happen even more commonly in kids, so if you've ever been around a child, you have that oral fixation, appropriately so, but one of the things they love to suck on is any combination of their fingers. So sucking of the thumb, sucking of fingers can lead to, if they already had that HSV1, they can give themselves a paronychia or a herpetic whitlow infection of the skin around that nail bed, sucking of the thumb. So something to ask if you come in with an infected nail bed in a child, does this child suck their fingers or suck their thumb? So most of the time your answers are going to be yes. You can see it on the how it looks there too, with any of these different papules, so it can present slightly different. I would say most of the time I see it in a nail bed like that though. You can see those vesicles in the mouth of the child, so if you have a parent that says, they just have really, really bad breath, this should be on your differential. Sometimes tonsil stones, there's a whole differential for halitosis we'll talk a little bit more about, but something on there to put as your differential. This one you can use your antivirals, so the same for adults, you can use this for kids too. So acyclovir, valacyclovir, and famciclovir are options that you can do. I usually send them home with a refill, because you know this is going to be a recurrent pattern. So here is your first script with refills to be able to pick up to use if this reoccurs. That's how I practice. Some people would rather see them each time and be able to know and document how long in between these reoccurrences it is. Up to you how you would like to practice. Do I need you to know anything else on there? No? Okay. A couple of different ones then while we're still kind of looking at some of these exanthems. Some of the other things that are going to manifest on the skin. So pinworms. Pinworms are really uninteresting diagnoses. Again, you've already seen the nematodes and the roundworms, and you had micro, you had all of that stuff. So the biggest thing to know is it is a worm, Enterobius infiltrus. So this is a pinworm. Kids are gross. Don't know how many times I can tell you that. But they are, so the eggs themselves are ingested from usually their little, scrubby little hands. Eggs are ingested, then they lay their larvae. The larvae grow, and over the course of about a month, migrate their way out to the anus. Really gross. I love kids, I do. This happens very, very prevalent, so you see it all the time. And the nice thing about this is though it's kind of gross, you're like, really kids, like you're eating worms and what's happening? There's really no serious outcome. It's more of an annoyance symptom that you want to manage rather than having a serious or bad outcome. So that's one thing that's kind of nice about this. If you just loved micro and the system and how it all happens, this is for you. I'm not going to necessarily test you on the larval stages of the pinworm. Assume that you got that from infectious disease. So what I do need you to take away is what this symptom is going to look like. Nocturnal anal pruritus. They have an itchy butt at night. Nocturnal anal pruritus. Put that in your brain. That is pinworms, right? So during the day, they actually aren't as bothered by it. The worms themselves will kind of involute into the rectum, and at night is when they come out. So nighttime butt itching. That's what I need you to see. You will start seeing this though, because it's not that it doesn't occur in the daytime, but you'll start seeing it anywhere you go. So you'll be like in Costco and you just see this kid with their hands down their pants, right? You see it at the playground, you see it all kinds of places, and I sit there and I think, oh my god, that kid has pinworms. and you're like, just what this, right? The tape test. Who knows what the tape test is? What is the tape test? Yeah, you literally give them a tongue depressor, parents a tongue depressor, and you roll up tape and you put the tape on the bottom in the morning. See if you can collect worms. That's literally all you do. Highly specific, highly sensitive. Again, wizardry there. Your treatment, I will need you to know the treatment, because a lot of times they're gonna come in being like, my kid itches their butt all the time, I see these little worms here, they're in a plastic bag for you. And so what you are actually, as the primary PA, need to know is, what do you do with that then? You don't need to necessarily do a workup to make a diagnosis, how do you treat them? So your first line treatment is going to be albendazole. So we give it ×1, repeat it in 2 weeks. You're going to treat everybody about it. You can do mebendazole or pyrantyl palmoate as a secondary option. You can do that. And everybody in the family needs to be treated, whether they have symptoms or not, because you do not know what their grimy little fingers have touched and what has been ingested, and if they are in that month-long incubation period. So treat everybody in the family, and you're going to change bed sheets, you're going to wash all kinds of their clothes, you're going to try to get rid of the egg burden as much as possible. So, and wash their grubby little hands. There's the Scotch tape test if I did not do an adequate job of explaining it and how you would explain it. And these are what the little worms themselves will look like. You would be shocked at the things that parents will bring you pictures of. It will look very similar to that. What I need you to differentiate that with is scabies. So scabies is going to look very different than that. But there's no real serious health complications with scabies, and it was a worm, or with pinworms, it was a worm. This one is now a mite. And so this one, in some ways, is, to me, even worse, because these mites crawl into the epidermis and functionally poop into the skin. And that is what's causing this highly inflammatory and high itching response, is having a mite poop under your skin. That's what's happening to this child once they burrow. Very, very contagious, and they love to have those places where they can burrow. So they'll go to anywhere with a crease. So under an armpit, in the fingers classically, in the neck, kind of anywhere where they can burrow, and it's going to be a little bit harder for somebody to get them away before they burrow. The reason that is under differential with pinworms is because the itching is severe and is at night. And so that's what they're going to try to distinguish. Can you distinguish when it's not as serious and it's nocturnal anal pruritus alone, or when it's scabies? So that's going to be your differentiation. It's going to be a little different in your distribution with a baby. So a baby still has all those folds, but they're going to have a harder time getting rid of it, so it's easier for these mites to burrow. So for a baby, you see a different distribution pattern. It's not classically in your fingers. So I don't want you to get thrown off by that on a question where you're like, wait, is that eczema? Is that, like, what's going on? Because it's on the face, but everyone else in the family has it in the fingers. It's a different distribution for a baby. It can be really anywhere that you would see an exposed pattern, because the mite can get there. This is one, it looks, if you just saw that baby, you might be like, oh, this is a exanthem, or oh, this is an impetigo, or oh, this is an eczema. So most of the time, this gets missed as a diagnosis. And somebody, a provider, myself, have done this. You give antibiotics, you give steroids, you give something else, and it might work for a little bit, but they're going to come right back with the exact same symptoms. So if you give something and it doesn't work at all, start thinking, what else am I missing on this differential? And so if you, on a question, see, they were given topical antibiotics with no improvement. They were given a course of corticosteroids with minor improvement, and it's now worse. Think scabies on your differential. So this is just some examples. If you see this, kind of burrows along the lines, burrows in places, and the distribution pattern of the baby. Your treatment for this is going to be permethrin. So you are going to apply this to the entire body. So the face, including the neck, everything is going to be there. You're going to leave it on at night. So all night, 12 hours. This one is not going to affect the eggs. So if there are still eggs that are there, you're going to end up having to retreat in another week to make sure you get everything. And you're going to treat everybody in the house, get rid of and clean and all the stuff, the bed linens and all of that fun stuff. This one is one that has heat specifically as well. When they come back and say, I swear to you, we did the treatment, we did the permethrin, we did it a week later, and I am still so itchy. Couple of things. Is this a treatment failure? Yes or no? Or is this a reaction that is this hypersensitivity and prolonged hypersensitivity reaction from having poop under the skin? So that's a big differentiating factor there. So do you have new lesions? Probably a treatment failure. Do you have no new lesions and you just are still super itchy? It's probably the hypersensitivity. So way to distinguish that. Lice, last but not least, certainly. None. Again, you can have all the different types of lice. Head louse, pubic louse, anywhere. This one's interesting to me because we always think that like you see lice and it's gonna like jump on you, but it's wing lice. It can't jump. It's gonna be from direct contact. So it can't fly. So you have direct contact with this infested individual. I read an interesting article recently that we saw an increase. We used to see it more in little kids who were sharing brushes and combs and playing with hair and all that kind of stuff. We've seen an increase in adolescents and young adults from selfies. So people are doing selfies heads to heads, and that is how the lice are spreading. So just be aware. You see it with selfies. Very, very itchy. So that's again why it's on your differential. So where is it itchy? So this particular pattern you see behind the ears and along the hairline of the back. So that is typically where you see a lot of itching and even skin breakdown from that. The way we're going to look at this is, can it be knocked off? So dandruff or any kind of seborrheic dermatitis, if you lift up the hair and you flick the hair, that is going to just fall. Lice are not going to fall. They hold on for dear life. So there, that is how one of the ways that you are going to be able to distinguish that clinically, is it knocked off the hair shaft. And again, that region that you're going to see it. It likes to be kind of up in the hair, so it's closer to the scalp, closer to that skin, but it can be anywhere in the hair. So it can be in beards. It's less common in beards, there's a little bit more oil in that typically, but it can be anywhere in the hair, pubic hair, beards, really anywhere where there's a hair for that neck to hold on to. Most of the time, people won't come to you for the first line, so do be aware that your first line is your permethrin. However, most of the time, people have already done the over-the-counter product and they've come to you because they can't get rid of it. So yes, be aware of this first line, but what I really need you to be aware of as the primary care PA is your second line. Most of the time, you're going to see these resistant cases, they don't know what else to try, and now they've come to you. So malathion or ivermectin, either one of those are what you would be responsible then for prescribing. So if they haven't done the over-the-counter treatment, that's going to be your first line permethrin. Your second line is then what you need to be aware of, malathion or ivermectin. Same stuff, bath towels, linens, get rid of that. Washing, and then this is where I differ from the guidelines. You practice how you want. They say take your brushes, combs, soak them in detergent or rubbing alcohol for 1 hour. I say get new ones. So up to you how you practice. I have taught you the guidelines. What you recommend to your patients is up to you. I usually say let's get new pillowcases, let's get new brushes, new hair ties, all the things. And just kind of start over. And then back to me, because now this direct contact, if you think about anywhere where their head has been, along a couch, in a car, anywhere where it's had direct contact, just be aware of that for the patient. Okay, what is your distribution of spreading of the measles rash? Yep, the hairline, so we do particularly the hairline down. How does it recede? Same way, yep. What about rubella? Face and down, and then how does it recede? Same, face and down. What does varicella do? Where does it start? Trunk and out. Yep. Who are the people that we worry about for parvovirus? Pregnant? And anybody that has anemic, but and really, what's your bigger category? Red blood cell issues, baseline. Yep. What are the other names for parvo? Infectious disease? Erythema infectious. Good. When is a patient with varicella no longer contagious? When can they go back to school? Everything is crossing over. Yep. How do you treat lice? What's your first line? OTC permethrin. What are you going to prescribe them for your second line? Malthine and ivermectin. And is anyone itchy? Okay, we did it. Oh, right on time. Cool. I will see you guys at 3, and we will do round 2 after this.